So I actually don't. I'm never asked to give this talk, so it was interesting to do. But I found it useful because I think in 5 years it'll be great because I'll be able to have surgical AVR, a historical perspective in about 5 years for our fellows, because we're not going to really be doing it anymore, and they can say, "You used to do that." And as a disclaimer, I do both surgery and the transcath, and I do think surgical AVR is a phenomenal procedure. But so when we're talking about surgical AVR, I mean, there's a lot of options, and Mike just discussed them. But we have different tissue conduits, the Ross procedure, mechanical valves, and a lot of increasingly available new valves as well. So this is an old slide, but just to give you a perspective, and this does include mitrals as well, but there's been certainly an increasing use of tissue valves for these procedures, with a slow decline in mechanical valves. I'd say, mechanicals are largely driven by the mitral space or the third world. Though I think lately there's been a little bit of a resurgence in mechanical AVRs in the aortic position, particularly in younger patients with protocols where we can reduce anticoagulation. So what's the data on this? So I think probably one of the really biggest studies is from a group in Portland, and they took 4,600 patients who had undergone AVR at their over a 42-year period. And basically they showed just a marked improvement in survival compared to the natural history of the disease, and an improvement it was found to be cost effective in terms of gain of quality adjusted life years, and the effect was regardless of age. So this is the experience, again, out to 40 years, and the survival is quite good compared to the, on the left, are the unoperated the unoperated patients. And so without question, and the natural history of this disease is fatal most of the time, and certainly, and we've even shown this in the partner and core valve trials against medical therapy, that fixing aortic stenosis without question is important. Now in the same study, they broke it down based on age. So even as we get into the patients well above their 80s, there still is an improvement in terms of it still makes sense economically to be treating these patients. And again, this is all surgical AVRs, and obviously the trend has changed with TAVR. But it's really remarkable. We've seen over time, this is from the STS database, and there's actually been an update of this recently, but based on over 100,000 patients, and it's this database where we get this STS risk score, and obviously it gets recalculated over time as we learn more about the patients. But you can see that there's just been a trend over time to a significant improvement in the mortality of these patients. And when we talk about STS score, understand we're talking about a 30-day or in-hospital mortality. So this isn't long-term, but it's the short-term risk. But down to a reliable mortality less than 2.5%, which is very impressive and a significant improvement. Again, even if you look at this based on age from the earlier experience in 1997 to a little more contemporary in 2006, there's still an improvement. We've just become better at the procedure. It's probably due to valves. It's due to our technique, patient selection. There's a lot of factors at play. And this isn't obviously just in the US. This is from the UK registry, looking at the number of procedures, and this is isolated AVR procedure. Again, this is now 131,000 patients, and there's been a continued decline in mortality. And even when this is combined with coronary operations, there's still a significant improvement. Now, what about other populations? Mike kind of alluded to some of this, but this is a study looking at patients who are having reoperative procedures, and kind of broke down. It was 744 patients at 7 European sites, and they broke it down, did a kind of a sub-analysis between those that were less than 80 and greater 80. Even did propensity matching with 84 of the patients, and found that the mortality was actually similar. In fact, if anything, there's a trend in the greater than 80 patients for better survival, which was probably when they're above 80 in a re-op, we tend to be probably a little more careful about patient selection in that population, whereas someone in their early 70s are going to be much more aggressive of operating despite other comorbidities. But the point being that even patients who have to have a reoperation at advanced age still do very well. I mean, of the reoperative procedures we do, I think a re-op AVR is one of the more technically easy but also more successful reoperative procedures when it has to be done. In moderate risk patients, this is a study from the Mayo, and so they looked at just intermediate risk patients, so 4 to 8%, and this is, I'd say most of us probably now for 6% and higher, we tend to be, probably the far majority of those are getting TAVR. I mean, 8% is just a no-brainer, I think, for most people. Again, there can be exceptions. If annulus too large, that doesn't mean we're not going to operate on them because they still do well. But this is still this is probably by European standards, this would be considered a high-risk group. I'd say by evolving U.S. standards, they're becoming a high-risk group. But median age was 80. 53% had concomitant experience, and their early mortality, 3-day mortality, was only 2.8% with a stroke rate of 1.8%. It wasn't a core lab. But what's most interesting in this, in this intermediate risk population is they looked at survival curve for age and matched population that didn't have aortic stenosis, and we've shown this in other trials that basically the survival is the same. I mean, this is one of the, the nice thing about treating this disease as opposed to, patients with CABG, they're always going to, the survival is not going to be as good as matched controls who do not have coronary disease. But with aortic stenosis, we fix the aortic stenosis, they do well. If you don't fix it, they do worse than most cancers, and if you fix it, they can live as long as they would otherwise, and this has been shown in just numerous surgical studies. We obviously, it's I think really the best data we have now on surgical valves is coming from the TAVR trials, because they're all core lab adjudicated, or core lab analysis, CC adjudicated events, neurologists looking at the patient. So I think we're really getting a good understanding, and my focus isn't going to be on the difference between the two. This slide, I couldn't delete the TAVR part, because I had that data for the partner trial. But this is a high risk group. I mean, certainly higher risk than I showed you with the Mayo experience. And and what's more important, and again, all these studies talk about 30 days, but 30 days is an important point, but much less consequential to the patient, and they need to understand this. And in a high risk group, to have a survival of less than 20% have expired at a year is still impressive. These patients, by kind of definition, with an STS, in the 8 range, or their 5-year survival, if they never had aortic stenosis, is not going to be very good, because they're all high risk because of their comorbidities, not because their AS is worse than somebody else's. So these are good numbers. And when they looked at the patients who had an STS lower than 7%, so generally a lower risk population, a lot of these guys have lower STS because they don't have some of these other some of the other kind of non-described factors, but still very impressive mortality. In this case, it did happen to be inferior to TAVR, but they're still good numbers. From the partner trial, they had the high-risk numbers were similar to what you saw. And now we just barely have intermediate risk data that was presented at ACC this year, and this is 2-year data. But with we see an early jump in the first month, which is what you're going to see with all these procedures. I mean, even TAVR for that matter, because they're procedural related deaths. But 85% survival at a year and 80% at 2 years. So this is a much more viable population, and they're doing well with surgery. This is a study from looking at centers in Michigan, and they basically, the question was, how do people do, is surgeon volume a predictor for success for this procedure? And while this was actually not statistically significant, so the this is the number of cases at the bottom, and this is the observed expected mortality based on the STS score. So you want to be the higher volume centers. There's visually a trend for it being better here than the lower volume, but it actually wasn't significant. However, if you looked at hospital volume, there was a change. So basically, if based on the other analysis, a low volume surgeon, their outcomes are generally similar to the higher volume. I mean, that's at least statistically that was the conclusion of that. However, based on the hospital, there is a difference. So if you have surgery at a high volume hospital, you're going to do better than you do at a lower volume hospital. And this is looking at the patients based on their risk stratification, and you can basically see that kind of along all risks, the green, which is the high volume hospitals, are almost always below, reliably below the observed to expected mortality, indicating that you're probably better treated at a higher volume place, and we're starting to see this with TAVR as well. Now, what can we expect from the durability? I'm going to focus on tissue valves. Now, I'm mostly going to present data on the Carpentier-Edwards, and that's largely because that's who gave me the better slides, not because I have a preference for it, but I think they're similar. But really, the good durability data has come from two valves, and that's the original Carpentier-Edwards valve, which is a bovine pericardial valve, and the Hancock 2, which is a porcine valve. But this is death, and you can see it's out to 20 years. Granted, the number at risk is only 3. I mean, a lot of these, you can really see the difference between some of these, the surgical trials that these valves were, where we did the studies on the valves versus the number that we're seeing in the TAVI trials. So we're going to get very good data as we follow this out. But the actual freedom from death at 20 years is 85.8%. Freedom from thromboembolism, it's 1.7% per year. It's existent but not bad. Freedom from endocarditis, there's about a 10% risk over 10 years with these valves. Structural valve deterioration. Now, ironically, we found that younger patients don't get as much durability out of the valves than older patients. And this is, due to, I don't think anyone really knows whether, my theory is because it's stressed more, but a lot of people say that's not the case. It could be due to calcium metabolism. It can be due to a lot of things. But just as we progress from patients so this includes patients who are 60, their, actuarial freedom is 77%. As you start getting older, it goes up to 81%. This is the mid-range patients, but as they get older, the actual freedom is 96% from structural valve deterioration. So the patients actually, the valves tend to do better in older patients, but it's still very good. This is the Hancock 2 literature sorry, I don't know why that jumped ahead, but the freedom from structural valve deterioration at 20 years in those older than 70 is 99.8%. So that's in this study they compared it to MitraFlow, and it was much better. Really we talk about durability of the surgical valves as being one of the things that is one of the strengths of surgery, and I think that's absolutely true. That being said, I don't know if any of the surgeons here in the last couple years have put in an original. In fact, I don't think you can get the original Carpentier valve. Hancock 2, I mean, you can still get. I don't know if you ever use it, but we've kind of all moved on to different valves. So the valves we're using now are largely based on these valves, are actually not the same ones that we have this long proven durability. And I don't think we have any reason to believe that the newer valves are necessarily going to fail earlier, but we don't really have the same experience. This is a more contemporary Mosaic, which was based on the Hancock. It had some calcium mitigation and some fixation differences. So this is probably the best data we have on a more contemporary valve that's being used now. And again, very good numbers. Freedom from explant 81% out to 7 years. And even based on age, we again see that the older patients do a lot better. Numbers are small, but it's almost nothing in the patients above 70, but in the patients less than 60, you can expect that these patients are, most of them you'll certainly get 10 years, but you're going to start seeing it dropping off soon after that. The echo findings, the valves perform very well. They do. Again, the best hemodynamic data is from these TAVR trials, so this is why TAVR's here, and I'm not trying to downplay the surgical valves. I mean, the hemodynamics are clearly better with TAVR. At least the forward flow hemodynamics are better, but I think, my feeling is in most cases this is a clinically insignificant difference. But the reverse flow hemodynamics are clearly not as good, but you can see in the surgical data, I mean, this again is the best data on PVL, that we have, the overwhelming majority of patients have 0 PVL. With only a small number, and these tend to probably be either technical issues or sometimes they get infections after, and the same has been shown in the core valve trials. That was from the partner trial, but again, excellent hemodynamics that last out to, we now have 5-year data on the partner patients and above 3 in the core valve patients. Still, excellent, really minimal amount of and this is total aortic regurgitation, not PVL. PVL again is almost nothing in the surgical population. You can develop some degree of central aortic insufficiency in the surgical valves. So in concluding, I think surgical AVR, the outcomes are excellent. They're certainly getting better. I think that's due to better patient selection, better management of the patients. We have better valves now. The new valve options I think are helping us, but we don't know. Some of them are very novel concepts, which is nice, and that's the kind of stuff we want to do, but the durability is unknown. I'm not advocating that we should all go back to the original valves, but it is unknown. And it's certainly a field that is threatened by TAVR, which I think is okay. But it's surgical AVRs is not going to go away, but I suspect as we're enrolling in low risk patients, and I think the landscape will drastically change over the next 5 years. Thank you very much.